Welcome to our module, which focuses on the second half of the consultation. Just like a game of football, a GP consultation is a game of two halves. The first half is very much about the patient doing the talking and you achieving timely data gathering with the use of silence, active listening, cue handling, reflection, short, succinct questioning, and focused questioning to help establish what's going on for the patient. What may be the medical issues at hand? What's the likely differential diagnosis? Confirming and refuting that to come up with a working diagnosis. The second half of the consultation is very much about you talking, because it's very much about information giving. But of course, yes, there has to be patient contributions in this second half, primarily about confirming their understanding of your explanation, their buying into the management plan, and their understanding around possible review and safety netting. So what might you have to do in this second half? There is actually a great deal that you may have to do. It may involve examining the patient. And that may, of course, be hands-on, or it may be patient-assisted examination over the phone or via video link. It may require you giving credible reassurance around an undue anxiety the patient may have. It will be delivering an explanation that is relevant and makes sense to a patient and actually contributes to achieving a shared management plan. It may involve negotiation, particularly when a patient's expectations is at odds with what you believe to be in their best interest. It will involve some shared decision making around creating a management plan in line with current best practice and the evidence base, and a process of appropriate review and safety netting if it's warranted. So let us consider examination. There are a number of reasons why we choose to examine patients. Firstly, to discriminate between likely differential diagnoses and exclude possible sinister pathology. 2, assessing the severity of illness, trying to work out, can I manage this in primary care or do I need to refer? And then finally, examination can be very useful in patient reassurance when a patient has a real fear around potential underlying illness. With regards to the types of examination, we're all very familiar, of course, with hands-on examination, but it's important to remember that as the bulk of our consultations are telephone and video, that we need to become skilled at patient-assisted examination. Can the patient at the end of the telephone check their temperature, their pulse, their blood pressure? Are they able to do specific clinical tests like the slump test in possible sciatica? So there are a wealth of examination skills that are required of a modern GP that weren't necessary a few years previously, just because of the changing nature in the way we consult. Now let us consider reassurance and the art of providing credible reassurance. We have all had at one time or another a patient who's got a real fear of some underlying pathology. As the consultation unfolds, it becomes apparent from your history and your examination that there is in actual fact a far less serious likely working diagnosis. Often what transpires then in the consultation is an attempt at reassurance, something that goes along the lines of, I'm really pleased to say that you were worried about a brain tumour, but I'm very much reassured and I don't think that you've got a brain tumour. So I think you've got, and then the doctor embarks on their explanation of what they think is going on. Problem, of course, is the patient hasn't actually been that reassured because they're sitting there thinking, well, how does he know that I haven't got a brain tumour? He hasn't done a scan. And as a consequence, they're not really engaging with the doctor's explanation. They're not really engaging with the management options that the doctor is trying to share. So how can you give credible reassurance? Well, it's a three-step process. Firstly, you've actually got to vocalize the absence of the symptoms of the condition that they're worried about. You've then got to vocalize the absence of the signs of the condition they were worried about. Then you have to provide an alternative diagnosis, and soon followed by an explanation of that diagnosis which makes sense of the symptoms they have. So an example might be, you mentioned you were worried about brain tumour. And when I see patients with brain tumours, they often have headaches that are waking them in the morning. They can sometimes be vomiting. They may have blurred vision, particularly when they cough and strain. They may notice that they're becoming clumsy, having problems with coordination, perhaps personality change, memory change, or more dramatically, even seizures. Now, from what you told me, you have none of those symptoms. Also, when I examine patients who've got brain tumours, they often have changes, at the back of the eye, in the way that the nerves are working, particularly around coordination, power and sensation. And when I tested those on you, I'm pleased to say they were all normal. So putting it together, you haven't got the symptoms of a brain tumour. When I examined you, you haven't got the signs of a brain tumour. What I think you've got, from what you've told me, is a condition called tension headache. So by taking this three-stage approach, the patient is able to appreciate why you are reassured as a doctor. And because they're able to appreciate the reasons why you're reassured, they themselves can be reassured. So this is something that is well worth practicing. And sometimes when you're embarking on a consultation, exploring their ideas, concerns, expectations, picking up cues, you will often identify when a patient has a real anxiety around a medical condition. And one option that you've got, bearing in mind that you're very likely to have to provide credible reassurance, is to use what's called a signposted aggregated list. And the example would be, as I gave earlier, when I see patients with brain tumour, they often tell me that they've got headaches which may awake them or first thing in the morning, blurred vision, limb weakness, clumsiness. Is any of that you? They go, no. And then you add other things that they tell me is that they may have personality changes, memory changes. Is this something you've noticed? No, doctor. And by using this approach, already the patient is starting to think, I haven't got the symptoms of a brain tumour. And you're actually paving the way for credible reassurance in the first half of that consultation. So now, why don't you have a go? If you're by yourself, just verbalise that example of credible reassurance as though speaking to a patient who had been worried about brain tumour. If you're with your trainer, you could also have a go. In terms of half-day release, why not break into trios and then one of you have a go being the patient, the other the doctor, and then the third person actually assessing whether the credible reassurance objectives are being met. And then take your turns at having a go at being the doctor. Moving on to explanations. Explanations are of great importance, as if you're able to give an insight into what is going on, an understanding of the medical condition you believe them to have, then the patient is A, through understanding in part, reassured. B, it can actually make a real difference to them understanding of the relevance of the options that you wish to share. And C, that helps achieve shared decision making around the management plan. So how do you actually make sure that your explanations are adding value to a consultation? There are 5 things that you must consider around your explanations. Is it actually making sense of why they've got their symptoms? Does it explain causation? Well, why me? Is it shaped by the patient's situation, perhaps their ideas or their concerns or expectations? You cannot use generic standalone explanations. They've actually got to be tailored to the patient in front of you to improve their relevance. Then 4, does it make sense of the investigations that you wish to pursue? And finally, and perhaps the most important point, will it make sense of the management options that you wish to share? In order to satisfy these 5 key components of a good explanation, you do need to rehearse and practice your explanations. As you know, in the moment with a patient in front of you or on the phone, trying to construct an explanation that actually satisfies these 5 criteria is virtually impossible. And even if you do manage to do so, what it does mean is that so much of your thoughts, intellect have been geared to creating this explanation, you're not really hearing or seeing how the patients are reacting to it. You're probably missing the cues that perhaps you may have lost the patient with your explanation. So let us consider some of the rules of the road for explanations. They do need to be brief. They've got to be under 60 seconds just because of the time pressures you're under in real life general practice. Ideally, they should be around 40 seconds and still achieving the 5 key objectives for the explanation. In order to improve its comprehensibility, it should be jargon-free. You might consider, might a diagram help? Might analogy help in terms of understanding? But you have to be aware that analogies can crash and burn. They can be confusing, distracting, and not adding to an explanation. So you do need to think long and hard before you embark on using analogies within explanation. The other thing you must always consider is the patient still with you? Are they understanding your explanation? In face-to-face consultations, of course, you get a wealth of non-verbal cues. In the explanation, if there's eye contact, appropriate to have a facial reaction, the patient is making appropriate comments, they appear to be clearly understanding, that is really helpful. Conversely, of course, if their eye contact has been broken, they're looking perplexed, they're really silent, you are getting cues that perhaps this explanation isn't working for that patient, in which case you've just got to abandon that explanation and have another go at explaining their condition. In terms of telephone consultations, of course, you don't have that wealth of non-verbal cues, and you really do need to check in with the patient that they're still with you. But you need to do so in a way that's really timely, because you know that you've got so little time within the 10-minute time frame. So something around, is that okay so far? Get them to actually tell you yes, in which case that suggests they've understood, or no, okay, then you have to have another go at delivering your explanation. Now it's time for you to have a go. Pause the video and have a go at explaining atrial fibrillation. Remember to keep it jargon-free. Try and use short sentences to keep it timely. But most importantly, try and create an explanation that satisfies the key criteria. That is, making sense of their symptoms, explaining causation, making sense of the usual investigations and likely management options. Having had a go, why not then look at my explanation? The YouTube link for this can be found in the module folder. Reflect on how it differed from your explanation. Try and take the best bits from both and integrate them to make your definitive version. If you're working with your trainer, then this can be a great opportunity to compare your explanation with their explanation. In the module folder, you'll find a file listing common medical conditions, and this can make for a great tutorial with your trainer as you have a go, and then they have a go, and then you explain your integrated version to your trainer, helping embed it. If you're in HDR, then using that same list of common medical conditions, you can divide yourselves up into groups of 3, go to a breakout room, spend 10 minutes perfecting your explanation to ensure that it makes sense of symptoms, causation, usual investigations and likely management options. Then, having done this, return to the main room and each one of you have a go at showcasing your group's explanation. In this way, you will gain a real insight into how to explain a wealth of common medical conditions in a timely way that adds value to your consultation. So now let's consider negotiation. Negotiation is sometimes required in a consultation when a patient has got an expectation which doesn't actually fit with the best management plan. This expectation may be around their investigation, it may be around their management. The problem, if you don't deal with this issue, the elephant in the room, then if you go straight into embarking on an option share for their management, the patient isn't really listening to what you're saying. They're waiting for you to present the thing that they desire, that investigation or management plan. And as a result of which, you're not going to achieve shared patient decision making. So you've got to deal with the elephant in the room, and so you've got to mention the issue, and then you've got to think, okay, I've got to explain why the thing that they sought, they wanted, is not appropriate, And this may be around the fact that the working diagnosis has changed. It may be around the risks of it, or it may be around the lack of benefit to the patient. This, of course, then has to be followed by an alternative, what you think is most appropriate for them. And then, of course, the most important step of all is actually seeking their agreement, actually checking in that your negotiation and changing the agenda has actually worked. Because until you do so and know for sure, it's important that you don't embark on an option share because you don't know if the patient's really listening. So let's give you an example. Let's think about that case of the patient wanting the CT scan. You mentioned at the start of our consultation that you were worried about brain tumour and that you needed a CT scan. Now, if you remember, we talked about the fact that you fortunately don't have the symptoms of a brain tumour. When I examined you, you don't have the signs of a brain tumour. And that, from what you told me, it actually, your headache sounds like a classic tension headache. So with regards to a CT scan, there are risks. There is a small dose of radiation to the brain associated with a scan. A CT scan in someone with a tension headache is going to be normal. You can't diagnose tension headache with a CT scan. So it's not actually going to change what we're going to do, how we're going to help you. So what could we do instead? Well, what I would suggest is that we think about, do we just help you treat the tension headache with a view to seeing, is it getting better in a couple of weeks? Because if that's the case, then we can be confident, yes, we're managing you, we're getting you better, and you've avoided the risks of unnecessary investigation. How does that sound? So think about these key elements of negotiation when you're dealing with these type of issues in your consultations. Acknowledge it, explain why it's not appropriate, explain what your alternative offers, and get their agreement. Moving on to the clinical management of patients and management options. The first question you have to ask yourself is it appropriate to share management options, or do I need to be directive? So in the case of the patient with central crushing chest pain on the end of the telephone line, I'm afraid you've basically got to arrange the 999 ambulance. Or a patient with classic red flag symptoms that satisfies the 2-week wait criteria really just needs that 2-week wait referral. So it would be inappropriate to share options in that situation. In most consultations, however, there are a variety of options that you can present to a patient that's in line with best practice or the current evidence base. And what you've actually got to do is actually think about what you know about the patient. If you've explored their ideas, concerns, expectations, you've got an insight into their social situation, you can actually select out of the options that you could present the ones that you feel are most likely to be feasible and achievable, and hopefully, if it does fit with their expectations, desirable for the patient. And you lead with your first best option. In order to achieve shared decision making around this, of course, a patient needs to understand the positives and negatives and what's involved. And an analogy, if you like, is that sharing an option is very much like consenting a patient for an operational procedure. You would never think of approaching a patient and saying, I think you need a hemicolectomy. What do you think of that? Because of course it's not informed. They don't know why they need it. What are the disadvantages of saying no? What are the advantages of saying yes? Why, what does it actually involve? And actually spinning an option, explaining an option to a patient is much the same. So let's just think of an example. It's not uncommon to hear in recordings of consultations a registrar saying, given your back pain, I think physio's the best way forward. What do you think of that? The problem is, of course, a patient doesn't know what physio involves, doesn't know what the waiting times is involved, what are the benefits to them, what are the potential risks. So in order to spin an option so that you can achieve shared decision making, you'd have to approach it in a different way. From what you're telling me with your back pain, I'm wondering if physio may be the best way forward. Unfortunately, there is a 3 to 4 week waiting list until you're seen. The physiotherapist will take a really detailed history about what's been going on and will do a very thorough examination to work out exactly what's happening. They will then put together a program of stretching and strengthening exercises that you will need to do a number of times a day for over the next few weeks before they review you to see if things are improving. The advantage is that often patient symptoms do get better. In many situations, it can actually help prevent a relapse in the condition. Also, of course, because it's a physical therapy, there are no physical side effects other than the inconvenience, sometimes discomfort, of doing the stretching and strengthening exercises. So, what are your thoughts on physiotherapy? Now, the patient can actually make an informed decision. And this is so important. You've actually got to get their yes sets, their agreement, their buy into this. If the patient says, oh yes, physiotherapy sounds just what I wanted, you have achieved shared decision making, having only shared one option, because you have carefully selected the option out of all the ones that you could present that is that you believe to be the best fit for the patient. You've explained it. Okay, they've bought into it. That is shared decision making, and that's what we're looking for in a GP consultation, because only when you get a patient buying in and committing to a management plan are they likely to go through with it and actually get the benefit from it. So why not have a go at thinking of some of your common interventions? What about counselling or CBT or physiotherapy? What I'd like you to do is actually verbalize how you would spin that option. What does it involve? What are the advantages? What are the disadvantages? If you're with your trainer, have a go and make sure you get that yes set. Clearly, in real consultations, if you don't get the yes set and clearly the option you led with wasn't a good fit, you just have to roll with that and present your second best option. But again, spinning it so the patient can make an informed choice. Let's now think about review and safety netting. They are two different things. A planned review with a patient needs to have an objective. It needs to have a specified time interval. And of course, you need to vocalize this to the patient. So not only when you are seeing them, but what will happen in that review. Is it relating to seeing how their symptoms are improving? Is it relating to seeing if they're getting any side effects or problems with the interventions that you've suggested? Is it about talking around results of investigations that you've instigated? Safety netting is a process that you're putting in place to ensure that any unanticipated but possible or should I say likely, adverse outcomes are identified early by the patient. They know what to look for, and more importantly, they know what actions to take. So the role of review and safety netting are very different. Not every patient needs a review. Not every patient needs safety netting. So it actually has to be appropriate to what has gone on in the consultation and the working diagnosis. One of the things we see in consultations is that as doctors we tend to leave review and safety netting right to the end. Now this can present problems for GP registrars because they know they have an exit exam. There is a 10-minute assessment window. If you habitually leave review and safety netting to right to the very end of your everyday consultations, when it comes to that exit exam, you're very likely to do the same. And unfortunately, as a consequence, if the 10-minute limit is exceeded, you will have failed perhaps to have put in an appropriate review and safety netting. So what I would suggest is that you consider a different strategy in real life to embed it so that when it comes to the exit exam, you're in a better position. So do your explanation. Lead with your first best option. Get the yes set and the patient buy-in. Then do appropriate review and safety netting. And with whatever time you've got left, you can talk about additional things that a patient may choose to do in order to help themselves. By taking this approach, you will ensure that your review and safety netting occurs within the usual 10-minute time frame. So having done review and safety netting, if that was indicated, what can you now do with the patient? Well, this is an opportunity to explore other things that may add to the management plan, things that they may do that could make a difference. It may be lifestyle changes. It may be self-help. You may be talking about things that you may do at review in terms of changes to a possible management plan if things aren't working out. Often it's about sharing informational resources with a patient. Now, this is where registrars often go wrong. You'll commonly hear in recorded consultations, I could give you an information leaflet from Diabetes UK on type 2 diabetes. What do you think about that? Unfortunately, this doesn't really add a great deal of value to your consultation. I want you to think about the last time you went to London. Often when you go to London and you're walking down one of the big streets, Bond Street, Oxford Street, they often have men, women, often students, handing out leaflets, basically pushing them into your hand as you walk down the street. What really happens is you hold on to that leaflet until the next waste paper bin and you get rid of it. And the reason for this is you don't actually perceive there is any value or relevance to this bit of information that has just been stuffed in your hand. And I'm afraid that is the equivalent of your informational resource that you've just offered. What you have to do if you're offering an informational resource like a patient information leaflet, a web page link text to their phone, is explain what it contains. You know, what is the value to the patient? What is the relevance to the patient? And then ask if they're, if it's something they would like. If they buy into that, then they're much more likely to use that informational resource. So an example might be, I'd like to text you a web page from Diabetes UK. It's one of the big UK charities. It focuses on a patient just like yourself that's just been diagnosed with diabetes. It explores a little bit about what diabetes is, why you've got it, talks about some simple tips around diets that you can make right now. It also talks about what we do as doctors, working with you in order to keep you healthy. Is that something you might be interested in? If the patient says yes, of course, this is really added to the consultation. Summarizing. Summarizing can be very useful. You don't need to do it in every consultation, but there are certain consultations where it is very important. If you've had a disgruntled or an angry patient, if you've been breaking bad news, summarizing the key points of the action plan are really important. In breaking bad news, the shock of the news that you've provided means that they will have only retained some of the information you've given them, and as a result of which they may not have heard exactly what's expected of them in terms of the management plan. So that summary of the key action points is going to be really important. In the disgruntled or the angry patient, again, you just need to make sure that you're both on the same page, that you both have the same understanding of what happens next. Because if the patient has a different understanding to what you understand, unfortunately, this will usually give rise to a really angry patient when what they expected, what they felt they were promised, fails to manifest. Another time when summaries are really important is actually where the plan is really quite complex. It may be a steroid dose reduction, or it may be some complex polypharmacy. So summaries are not always needed, but they can be very useful. And in these situations I've highlighted, they can be very important for patient safety and patient satisfaction. So now it's time to have a look at our YouTube clip that's embedded in the next slide. What I want you to do is to look at the second 5 minutes. You may recognize this consultation from the previous module, which focused on the first half of the consultation. What you need to do is actually use the consultation assessment sheet embedded in the link in this slide, watching and listening to the YouTube clip. You need to write down what the doctor actually says or did which contributed to achieving shared decision making. If you're with your trainer, have a discussion about what the doctor did. How did they achieve it? What could they have done differently? If you're in half-day release, this would make an excellent exercise in small groups. Having done this, you can use this type of approach for your own consultations. Why not look at the last 5 minutes of your last recorded consultation and just focus on the key competencies? Did the explanation fulfill the 5 key criteria that adds value? With regards to your option share, were you spinning your options? Were you getting the yes set and buy-in from the patient? Did your review and safety netting make sense to a patient? Was it appropriate for the condition? And of course, what other informational resources or advice did you give? This focusing on what you do in the second half of a consultation and getting feedback either from your peers or from your trainer can be very useful in significantly improving the quality of your consultations.